Okay, so this video today is going to be pretty short and sweet. It's going to be the original lecture that I was going to give about medications a couple weeks ago, just on the few medications having to do with substance use disorder and how certain medications can be used that have been approved by the FDA. So I'm specifically talking about medications that are not used off label, but are actually approved by the FDA for this intended purpose. And my original lecture was going to be the three for alcohol, and then a little bit about methadone. And then we got into a bigger conversation, which was fabulous. But for this, I just really, again, like I mentioned before, you're not leaving this class addictionologist. I would like you to know the most common medications, and I don't want to overwhelm because I really want you to cling on to certain medications. And as you go in your career, depending on where you go, that's where you'll learn the bulk of what you're going to know. So let's go ahead and just start. So you have the information because you do have what I know it's silly, it's a pop quiz next week. And I don't plan on this lecture being more than 20 minutes. So let's just get started. And I think two questions that I talk about in here, which you'd probably get it right anyway, because everybody was so engaged and as you guys always are, and attentive in class. So let's go ahead and start with the three. And again, we're not talking about all of them. There are several medications also used off label. For example, like gabapentin has been proven to help with reduce alcohol cravings at a certain dose, usually about 900 to 800, or sorry, 900 to 1800 a days, mostly in women, but that doesn't mean that it won't help in men. But we aren't going to talk about, Tegretol, and there's tons of medications. We're going to focus on the three I would say most popular, and again, FDA approved, so these were intended for the purpose. So the first one, I think, again, as I've mentioned before, is probably the most well-known, which is called Antabuse. And Antabuse is an aversion type of medication used for alcohol use disorder, and it is considered a craving medication, even though it doesn't actually do anything in the brain to help you not crave alcohol. However, since it has such a dramatic and drastic effect and makes one sick, it's kind of like food poisoning. Once you get food poisoning from something, you don't want to eat it for a while. So once you take Antabuse, and Antabuse is prescribed at anywhere from about 250 to 500 milligrams a day, depending on the provider. And the medication is taken, and again, it doesn't work in the brain, has nothing to do with the brain, and it helps by blocking the metabolism in the liver of alcohol. So what that would mean is if you're taking this medication and you do take it once a day, however, one of the benefits is it lasts in your system once you start taking it for up to 2 weeks. Some people, it may just last a week, and then on the 8th day, they can drink and be fine. Some people, it takes a full 2 weeks. You just never know. So, and I actually just had a patient in, what was it, last Monday, who I always ask, because I was teaching the anti-craving medication class, and she had said how she just drank. I mean, when she said a little bit, we always have to ask, what is a little bit? Because a little bit to me could be a lot of bit to somebody else, right? And she had said that she had drank maybe it was like a half a shot of vodka. It was like a drink, if you will, like of it, like you're taking a drink of water. And she got so sick for days, actually for 3 days. And that's just the way her body was affected by the medication. And so basically, the most important thing to remember about Antabuse is that it is an aversion type medication because it averts you from wanting to drink because you're so scared of getting sick. And if you drink while you're on it, or up to 1 to 2 weeks after taking it, I always say 2 weeks, and not that we're encouraging those that are on the medication to drink after being on the medication, because usually if you're on the medication, you're on it because you are going to be abstinent. But again, that everyone's different. I'm just teaching the facts. And if you were to drink on it, it's basically, in essence, giving you alcohol poisoning because your liver cannot metabolize it. So it has nowhere to go. People do end up in the hospital. We do palliative care, IV fluids, because obviously, or not obviously, but if you didn't know, there's, there could be, everyone reacts differently. There could be diarrhea. There's definitely vomiting. You just feel horrible. It's like when you drink too much alcohol and you throw up, that feeling, it's like that, because in essence, you're having alcohol poisoning. And then you usually don't feel good for a couple days. Now, something to consider about this medication: do you probably need to be pretty cognitively intact to be on this medication. So if you had any sort of brain fogginess in the very beginning of your recovery, and you may not be able to comply with certain things, such as, we have to think about what's in the world. Alcohol's everywhere. So if I use hand sanitizer, I'm not saying you're going to get full-blown sick, throw up, but you'll probably feel a little bit flushed. You want to avoid anything with alcohol in it, such as perfume. That's why we don't allow perfumes in our programs, because based off of medications, and people tend to be a little bit more sensitive because they don't feel good. And so we want to make sure that our patients are very, very aware that if they start to feel a little bit flushed, they might remember, oh, I just hugged, my husband and he was wearing cologne, or things like that. So there's little lifestyle changes. And this tends to be one of those medications that scares people. But to be honest, I did not like this medication for many, many years and thought, no. But I'm having a lot more respect for it for certain people, because I have seen it make a huge difference. And for all the medications that we're talking about, there's no real timeline on how long to take them. I usually say anywhere from 3 months to a year is kind of the most common for the alcohol craving medications. But it just depends. Everything depends, right? So that's enough about anti-abuse. I think that we hit the highlights, the highlights of the medication. And a pro is that it is a cheap medication also. So that's always good. Okay, the next medication is Camprol. This is one that I would say is, in my experience, used the least, not because it's not good. The efficacy is not what I would consider to be, like right now, naltrexone, that's the hot thing on the market, right? And that's the one I'm going to talk about next. That's the one that can be used for opiates and for alcohol. But Camprol is a medication, and this is one, if you looked it up, it's not completely known how it works. However, in studies, it has shown to help with cravings. I tend to recommend this medication if somebody's very sensitive and has a very sensitive stomach. It tends to work very, very well. It's very gentle on the stomach, and it's not hard on the liver. So if somebody has a really, really, really bad liver, it works harder on the kidneys. So these are kind of just little things to think about. No, please don't sit there strenuously taking notes. Any questions I'm going to ask you from this portion is going to be a basic question, because again, not that you can't handle more than basic questions. I don't necessarily think that part is important, but I think that it's important for me to at least say it, so that if it sticks with you, great. If not, what's important? It would be important to know that anti-abuse blocks metabolism of alcohol, therefore making you very, very sick. That would be important, like black and white, right? This medication is important to know that we're not completely sure how it works, but we, unfortunately, if a person is not good at taking medication, not that they're not trying to be compliant, because remember, this is the one you have to take 3 times a day. And I can tell you how we think it works too, but we have to take it 3 times a day, once in the morning, once in the afternoon, and once like a dinner. And you have to take 2 tablets each time. And again, I think it's for marketing, because you have to take 666 milligrams with each dose. So each tablet is 333 milligrams. And again, I don't think I need to explain why you probably wouldn't want a 666 on your tablet for marketing reasons. So you have to take 2 tablets. So 2 333 milligram tablets 3 times a day. So that equals 666 each dose. If you don't take it and you don't do it that way, and you forget all the time, the medication's not going to be working. You must take it. You must have that therapeutic range in your body in order for it to do what we think it does. And what we think it does is actually basically balance out the neurotransmitters that alcohol affects in your brain quicker, therefore helping with anxiety, because many people that are coming off of alcohol for months feel a sense of just general anxiety to heightened anxiety. So it works similar, like honestly, like gabapentin. I look at those pretty similar. So if you're able to balance out those neurotransmitters more quickly, therefore your brain is healing more quickly. So that's kind of how they think Camperol works, and it does work in the brain on GABA and glutamate mainly. And GABA and glutamate, they play off of each other. So if one goes up, one goes down. So as most neurotransmitters, one goes up, one goes down. Those are the two that Camperol is most likely to affect. I tend to usually, if someone's doing well on it, it's great, perfect. If somebody, for example, the woman that explained how she tested antabuse, she is currently on naltrexone and antabuse. So you can use different medications. And I mean, I'm not a drug pusher, if you will, or a medication pusher, but sometimes, you know, I mean, this woman unfortunately had several relapses, and we came to the point of what are we going to do now? What can we do now? Now, then just the naltrexone is not working. We need to do something different. Let's try antabuse. Would you do that for us? And she did a contract with her husband, and to allow him to watch her take the medication every day to make sure both those meds are going in her body. And that's something that we tend to recommend. But again, everybody has their own recovery, and we don't want to belittle our patients, but it's more about accountability, because those cravings are so difficult. Again, I'm going to say it. Think of yourself sitting, let's say you don't have any problems with you're not in recovery. You've not had an issue with addiction, and you are really hungry, and you smell food. What happens? Saliva starts to come in your mouth, right? And you start to feel hungry, hangry, if you will. And that's just, I mean, like a fifth of what somebody would feel like if they're craving alcohol or heroin, or, oh my God, it's like nothing comparative to that. Unless you're a food addict. And then of course that's different, but we won't get into that. We'll stick on track here. Okay, so we have Camperol, which again, I think is not a bad medication. Again, we talk to the patient, are they good with medication? Maybe someone will be helping them so that they don't forget to take, however it is affordable. It's not hard on the liver. So if we have somebody that has a really fibrotic going towards cirrhotic liver, we're not going to want to give them something to potentially make it worse. And a lot of the medications, oddly enough, are a little bit hard on the liver. I know that sounds counterintuitive, but it is what it is. And I usually recommend Camperol being paired with something else, but try it first and see if it works. So I think that's enough about Camperol. Again, I just want you guys to see the medication and know, oh, I know what that's for. That's for cravings for alcohol. So I think that's the biggest thing. You don't have to know exactly, but antabuse, that's a big one. I think you should definitely know how that works. Hint. And I do think it's important just in general. It's aversion therapy. It doesn't go to the brain. Now, the hottest medication out there right now is naltrexone. And we talked about naltrexone, and my brain flubber, I don't even know what you want to call it, but whatever happened to my brain that day. So just a reminder that Narcan is the medication that you get if you either accidentally give your patient too much opiate medication and you need to reverse it. And it goes basically Narcan, naloxone, and naltrexone. They're all the same thing. They just all have different half-lives. And I don't know where my brain was that day. Luckily we have, all of you are very, like really care and which I appreciate so much, because sometimes our brains are not always working 100%. I'm sure you've been there. So it's important to, this isn't on your test, or your quiz, but it is important to know what Narcan is. I think that's important. So now naltrexone is a medication that can be used for both alcohol and for opiate cravings. And it comes in, and by the way, I'm not talking about Suboxone or methadone today on this. This is all just alcohol. So or I might very, very briefly, but this was more supposed to be about alcohol, because it's probably more common unless you're going into addiction and working in it in addiction. These are the ones that you will see the most of just in the general hospitals and whatnot. Maybe. So naltrexone basically, and now this is one like Camprol that works in the brain. So you can do one of two things. And for this medication, there is an injection called Vivitrol. It lasts for 28 days. It's 380 milligrams, and it is slowly dispersed in the body. And I think we did the math. It was like 13.8 milligrams a day. Naltrexone in the tablet form, you take once a day. It lasts for 24 hours, and you take 50 milligrams a day. And why do you take 50 milligrams a day? Because your liver breaks down a lot of the medication, like any medication. A lot of us don't even realize that we don't even really need a. That's usually why the injectable form of something is so much less, because your body has that first pass metabolism stuff that we're not going to talk about, pharmacokinetics. So naltrexone does one of three things, and I think is amazing. So number one, just having the injectable form available is great. We talked about the price and showing that the efficacy of naltrexone and Vivitrol and how it works. And I don't want to say it's the best one, because it depends on the person. It really does. It depends on the person. It depends on, so, I mean, a multitude of different things. However, naltrexone, it really is the hottest thing right now, because it has shown to really, really help those struggling with substance use disorder stay sober longer. Yes, relapses can be a part of the addiction process. They usually are. It's more common to have relapses than not to have relapses. And you'll hear some people say it's a part of the disease, if you believe it's a disease. And that's not the point of me being here, trying to tell you that you must believe it's this or must believe it's that. So think of naltrexone and Vivitrol the same, but I'm just going to call it naltrexone. Vivitrol, of course, is good because it's in your body. So it's in your body. You don't have to worry about it for a month. But if I have somebody deathly afraid of needles, I mean, that might not be the way to go, but then I will talk about accountability about taking the medication, because it literally just lasts 24 hours in your body. You could drink alcohol, and this one doesn't make you sick. So what it does is, and I'm not sure if you remember, because this is something that is not really well known, and alcohol goes to about 5 different places in your brain. And I would say probably 2 of the most important ones to know. And again, this isn't on your test, but just so that or your quiz, but so you know, is it goes to your opiate receptor. And a lot of people don't realize that it goes to your opiate receptor. And if it didn't go to your opiate receptor, I personally don't think it would be addictive, because the opiate receptor, out of all the 5 places that it goes, there goes GABA and adrenaline, glutamate, and one other place I always forget. All those other places don't go to the reward pathway. Remember, something's not considered to be addictive unless it ignites dopamine in the reward pathway. So all of those places I just mentioned, opiates are the only one. So if we ingest alcohol, and alcohol, one of the places that it goes to is the opiate receptor, we know that opiates are addictive. So I call it taking the bus. Once that opiate receptor is stimulated, it takes the bus over to the reward pathway and then ignites dopamine into the reward pathway. And once that happens, we feel euphoric. The euphoria is our reward, and the reward is our reinforcement to continue the behavior. And we'll talk more about addiction when next week we're finally finishing that up. When we play the Jeopardy, it's on the plan, so you guys will see it. But it's important because I really want to have some time to have some questions, and it tends to be a topic that a lot of people are really interested in, because it does affect so many of our lives, or I mean, those that are close to us, and just the world in general, especially right now with COVID and depression. And it's just very, very, very rampant, especially right now. We've never been busier at El Camino than right now. So naltrexone goes in, and naltrexone covers the opiate receptor. So if your opiate receptor is covered, you're going to have, it kind of makes sense that you're not going to have as many cravings just in general. And I ask my patients, I say, tell me how you think this is helping you. And they'll tell me. I will never forget one of the best conversations about this medication with one of my patients, and he told me, because I mean, I think books and research, I mean, that's all good, but I want to hear from the patient, because I think, I mean, we can learn so much from our patients, and if they're comfortable sharing, which usually they are, because I mean, who doesn't want to feel special, which they, in my opinion, they are, and their knowledge can help somebody else, and that's a proud feeling. So he told me, and this was years ago actually, and he said, well, you know, it's hard to kind of really know exactly how it's helping, but this is, sorry, my phone keeps going off. It, I used to think about alcohol, and I can't remember the exact amount of times. Let's say he said 37 times a day. Or actually, no, how he explained it. Before lunch, I would think about alcohol, like let's say 25 times a day. And now I'll notice maybe I'll think of it 5 times. But that sounds pretty good to me. I mean, if you're, imagine you're excited to go, this is probably not the best example, but it's what I can think of. You're excited to go because you're about to go on vacation, and you're like at work, and you're just waiting, you're waiting. And that's all you can think about is getting out of there because you want to go somewhere. So not thinking about it and being distracted would be good, because you want to get your work done, do it right, and then leave. So to have less cravings is very important for a certain amount of reasons. So this medication, naltrexone slash Vivitrol, works 3 ways. And that's one reason why also I think it's extremely, the efficacy is just going through the roof, is because, so it covers that opiate receptor. So you have less cravings. If you have less cravings, your neurons in your brain, they're like a muscle. So every time you're thinking about alcohol, or, and since we're talking about alcohol or drug of choice or whatever it is, it's like a muscle. It gets thicker and thicker and thicker. There's almost like a ring around it. And if someone were to do an autopsy, a brain specialist, they can actually tell you about how many years you've been abusing based upon how thick the nerve is on that neuron. I think that's just freaking fascinating. And the doctor and I that I work with, we disagree on this, but in my opinion, if that's happening, don't you think if you're not thinking about it as much and those neurons are shrinking, you're going to have quicker brain healing? And I've done research on this on my own, but he disagrees with me, but whatever. That's my my, we take our own knowledge over years and years and years and can make, yeah, maybe it's not 100% proven, but I have watched I think it was a TED talk on it, and then I did my own research on it, and then it just makes sense. So, and the quicker your brain heals, the less cravings you're going to have overall anyway. It doesn't mean you're one done and cured. There's no cure here. We're buying time. We're buying time for your brain to heal and to help you feel better, so that when you go to group, you're not craving so bad, and you're able to take in the information and the coping skills, right? When you go, hopefully, if you're in treatment, we just don't give you pills and say good luck, or no psychiatrist or NP that I know would do that. So that's one way it works. The other way it works, if you are to drink on naltrexone and or Vivitrol, you do have alcohol go into your body, you metabolize it, you're drunk. You can completely get drunk. However, your opiate receptor's covered, right? So you're not getting anything happening to your reward pathway. There's no dopamine release, there's no reward, and there's no reinforcement. So you drink, and honestly, you get kind of pissy almost, and upset because you can't get drunk. And I have never heard of anyone dying from this, because like I think I mentioned, usually people just end up passing out. And a couple of things happen. Number one, you have the worst hangover. It's like a double worst hangover. So it's even better actually in the big picture, right? Because it's like, oh, I made a mistake. Oh my God, what was I thinking? Or I wanted to test it out. That tends to be a very common thing. People want to test it out to see what would happen. And you actually can see, I really enjoy, that sounds so rude. But I enjoy actually hearing when my patients are explaining in group how they challenge this medication, and they're just like, oh my God, you can see yourself drunk and stumbling around. You can still get a DUI. It's in your body. It's just not in your reward pathway. So you're not feeling euphoric, and you can actually see yourself drunk. It's very interesting. So that's another way that it works, is that it doesn't get you drunk, doesn't give you the reinforcement. And then the next day, everyone I've ever talked to said they have a way worse hangover. So the three ways that I say naltrexone works, well, the two that are definitely how it works is it covers the opiate receptor. So of course it's going to help because we know alcohol goes to the opiate receptor, and it will not allow you to feel reinforcement when you drink if you were to drink on it. And then the third one, which is I still teach it and I explain it the same way. Hey, the physician doesn't agree, but this is my opinion. I say it more eloquently than that, but that it helps heal the brain quicker. And that's what my research has shown, and this is why. And then the patient can make up their mind. And again, Vivitrol works the same way. And the reason the efficacy now is so good and is because, remember how I mentioned we were all like guessing how much it was going to cost? I think that was around our pho conversation. When Claire asked, where's good pho in San Jose? I think that's who it was. Is that Vivitrol costs about $1,800 a month if without insurance. And we used to have to do so many pre-authorizations for it. And now, and naltrexone is not, it's very cheap. And now we don't have to do that. Not as often, because people are, the insurance companies are seeing, hey, I don't have to send somebody to rehab for $45,000 in this month if I just, we cover this medication. And it's not as new, but I remember when I first started, oh my God, it was hours on the phone. It was just ridiculous. So that there shows that it's, the research has showed that it's working. So those are the three basic FDA approved medications for alcoholism or alcohol use disorder. We've talked about methadone clinics, and that in order you can methadone is a pure opiate. You can prescribe it as a physician for pain. However, if you're prescribing it for opiate addiction, you must have a special certification to do that. A primary care provider is not allowed to do that. Because it's a very different way of doing it. You have to do correct dosing. It's a very particular way of doing it. So we are replacing one thing for another. It is considered harm reduction because we're obviously using something that can get you very, 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 very high. The death rate, people do die. And back to naltrexone real quick, it makes sense why that works. I mean, it covers the opiate receptor. So yes, people will challenge it. And I personally have not heard of anyone that has died, but I know that it has happened because you have that opiate receptor covered and people will use so much opiates that they will overdose being on naltrexone or Vivitrol. So education is very, very, very important, but addiction yeah, I'm not going to, I won't ever get off of here. And this is supposed to be quick. So it needs to be very well explained, but it works. So, I mean, people just talk about how amazing it works for them for both alcohol and for opiates. And for opiates, this would be considered, naltrexone and Vivitrol are considered abstinence-based because you're getting no euphoria. It's not igniting the dopamine pathway, all of that. So Antabuse, naltrexone, and Camprol are all considered abstinence-based. And naltrexone and Vivitrol, whether it's for alcohol or for opiate use disorder, is still abstinence-based because you're not igniting any sort of euphoria. You're blocking. You're not, remember how I said that kind of like that tickling? You're blocking the receptor. Now for methadone, you're not. It's a pure opiate. It's considered harm reduction. I respect both. Everybody's entitled to their opinion. And like I had mentioned before, some abuse the system, just like anything else. If it's used properly, and usually people do end up using it for a very, 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 it's very hard to get off of. And if you're, in most physicians' opinion, you don't plan on being on it for at least 2 years, it's not worth going on because it takes even 4 months to get your dose right. And it's a difficult medication to get the right dose because you don't want someone high, but you want them just enough in that receptor of the methadone so that someone can function properly and withhold a job. Because again, it's really hard to hold down a job when you're needing to, shoot up every 4 hours. Because most people, it's usually heroin, but it can be other opiates like Oxycontin, Vicodin, and all of that. But I would say 90% of methadone clinics are usually heroin users, in my experience at least. So we get that dose correct, and I've seen it do wonderful, wonderful, wonderful things, and I've seen it do unfortunately awful, awful, awful things. And we would have a death about probably every 4 months at the clinic, because somebody would use something else with it, like heroin and then meth, and just it would be a mess. But again, it's good to still know that it exists, what it can do. I think that breaking that stigma is really important as well, not just, yeah, hopefully you got a lot from if you did. Actually, I haven't graded it yet, but the addiction area, and we'll talk about more of this on Friday. And then the last one was Suboxone. Suboxone also is considered harm reduction. It goes under the tongue and it has a ceiling effect. So I've never heard of anybody overdosing on it. It's very safe. It also methadone is very, very cheap. Suboxone is not, God, I haven't prescribed it or been a part of it for so long. Same thing, you have to have a special license to prescribe it. I would say the average person is usually on like 8 milligrams in the morning, 8 milligrams in the evening. That doesn't mean there's not some people on it that are on 32 milligrams. Whatever you need for your tolerance, that's fine. Again, you can stay on this medication forever. Most tend to not. There, I would say, is euphoria for maybe the first couple days, but then we had mentioned before, it's not filling the receptor all the way. It's kind of just like playing with the receptor, so it's not locked in like with methadone, where you can actually get super, super, super high. Suboxone's not like that. Again, maybe the first day or two. And we have to wait. Remember, we have to wait because it has such a high affinity. That buprenorphine has such a high affinity for the receptor that if you have any opiates in your system or you're not in moderate withdrawal, it will go in there and pull it off, and your patient is now in withdrawal and there's nothing you can do about it. So the patient needs to be in moderate withdrawal. We use a scale called a Cal scale. We look at their pupils, we do their blood pressure. I can just usually tell because I've been doing it so long, but again, I still do the documentation to cover, COA. And because I don't want my patient to get sick, that'd be awful. But it's almost like a miracle. You give the medication and it's like, oh my God, I feel so much better. I would say 80% of the time it really is like that. It may be, okay, I feel halfway better, and then it takes a couple days, but it's, in my personal opinion, it's a really great medication, especially for chronic relapsers for opiates. So, trying to think. Yeah, so it ignites dopamine a little bit. It does. It gives just a little bit. It kind of just makes you in a little bit of a better mood. That's how I would say it. I've been around hundreds of people on Suboxone, hundreds of people on methadone. I can see the difference. Again, depending if the dose is correct, and that's really the most important part, right? Not really as much for Suboxone as methadone, because we don't want people walking around high or driving around and hurting people or whatnot. So anyway, I hope this was try to keep it short and sweet and kind of hit the highlights of everything. But of course, if you have any questions, let me know on Thursday, and I'll post this because unfortunately, I don't know what happened to the last video. So I'll post this under, and then I will do an announcement. I will also post an announcement of the medications that we're going to be going over. You'll see in our plan. I want to go through, remember how we had all those, the Quizlet stuff. I don't want to lose touch with the verbiage and everything. So we'll do a quick overview. Friday, we're bouncing around. So, and remember, I'm being evaluated too. So you'll see somebody else on there. Michelle Hampton, very nice woman if you have not met her. So, okay, I'm going to stop here. Let me know if you have any questions. I hope I didn't go over too far, and I hope you got something from this, and I hope that you guys enjoy the movie. And thank you for being so flexible about the last minute change. I just totally did not know that that was happening, and then we made it work. So hope you have a good day, and I will see you very soon.